We will start from the extradural dissection, then that how extradural dissection is possible and how we'll do it. Then we'll go intradural.
Thank you, sir.
Okay. Anything else? So since till yesterday we were here that we have to complete this exposure of the bone, like the temporal and the posterior fossa simultaneously, with the exposure of mastoid antrum, mastoid air cells, the all three. These are not three; these are just three out of four semicircular canals. That is the lateral one, anterior one, and the posterior. Lateral one and the posterior and superior. Lateral is this one, and the this is superior, and this is posterior. That is up to the towards the posterior fossa. And we discussed that for extradural exposure, it's very important that we should know the three landmarks. That is one of the zygomatic and the mastoid tip and the asterion, that is the junction of sigmoid sinus and transverse sinus. After this exposure, we have to nibble this bone like this one carefully and extradurally without giving hurt to the sigmoid sinus. As we have done this one, now what you will do extradural Penfield dissection, or you can say the detachment of the dura from the temporal area. Because our target is first the temporal area, later on it will be the posterior fossa. So this is the area where we have to detach the dura from the Penfield with the help of Penfield from the bone. That is called the dural propria. Okay, what will be the landmarks of the detachment and dissection of the dura from the bone? That will be up to the level of the foramen spinosum. That is, we know that the middle meningeal artery, first thing. And second thing, if you are doing properly, that it's up to the level of greater petrosal nerve, the greater petrosal nerve. When you detach it, so this is the anatomy of this one. This is tend. We have cut down the tend, but before cutting down the tend, we have to expose this whole area, this area, from here to here, not below to the transverse sigmoid junction. It will be secured, and we are not opening the dura. After exposing it, we will see two structures, that will be the greater petrosal nerve and the the middle meningeal artery. For to understand that how we have to see these two, this is the cadaveric approach, and it will help us a lot that all structures will be visualized, how it will be visualized, and what will be the landmarks, and where we will work actually, and how we'll approach. So, and there are a lot of triangles actually. This area, that is the middle, this is the triangles of the middle canal fossa, and this is the triangles of the posterior middle simultaneously both. So these triangles are actually the ways to get access to the medial structures and the posterior cranial fossa. So this is all about the anatomy. So anyone who can appreciate it, it should be good. So what is this structure?
The trigeminal nerve.
Trigeminal nerve, excellent. Okay. So our target is this area. This area we will target, and I will make it more proper, then it will be good. This area will be our target, and this is called the Kawase. This is the area of Kawase. Okay, that we call it the anterior petrosectomy, and this is actually the Kavas area. So what's the landmarks of this one? Here, this is the structure. What kind of a structure this one? Yes,
Greater
please.
petrosal nerve.
Excellent. Dr. Sana, you are there?
Yes, sir.
Excellent. So this is which structure? This is external greater petrosal nerve. Below to this one, what is this radius structure?
The internal carotid artery.
Let me change the color. What about this structure? This one? Yes,
Greater
please.
petrosal.
This is the greater petrosal. Behind there will be, this is this red one. This is internal carotid artery. Okay, this is internal carotid artery. It will go at the level of the labrum. Then this is the turn of the the internal carotid artery. So first lateral landmark will be the greater petrosal nerve. When we'll go medially, it has the landmark of look at here, that is the trigeminal nerve, and little bit posteriorly there will be the uh, uh, internal carotid artery. And what about these two structures? Yes, please. These. Yes. What about these two structures?
Sir, trochlear.
So, sorry, what?
Sir, trochlear.
Trochlear nerve?
Yes, sir.
This one. This is here, it's a trochlear, but what about this one? This is coming from here.
Mandibular division of the trigeminal nerve, sir.
Dr. Mustafa, what are you saying? How it could be mandibular division of this nerve? So this is trigeminal nerve is coming here from here. This is ganglion of trigeminal nerve. This is V1. This is V2. This is V3. So beautifully they are directed. So how it's possible that the trigeminal will be here? What is the area that is just posteriorly coming from here? This is internal acoustic meatus.
Okay.
Internal acoustic meatus on the posterior side. This is the middle cranial fossa, and this is the area of posterior cranial fossa. Two nerves come from here. That are two nerves. Which one? And one artery. Look at here. That is the 7th and 8th. Facial nerve. Facial nerve is coming here. It giving the branch that is the greater petrosal nerve. And there's a vestibular cochlear nerve. Okay. There is also the superior and inferior division. This is the superior division of vestibulocochlear. Just below to this one superior, there will be the inferior division of vestibulocochlear, and this is the labyrinthine artery. So be clear about this area, because this is very technical and critical area. If we are well aware of all these surrounding structures, then we can penetrate properly. If we are not well aware of this one, we will damage any one of this structure, and that will be permanent damage to this one, permanent deficit to the patient. Okay, and this is the cochlea. We have to save the cochlear area. Okay, so actually you should know this trajectory. This is the Kawase. We will enter from here. Any question?
No, sir.
No. Thank you. So, yes, this is another picture that extradurally, I told you that we have peeled, we have detached the dura temporal side from the bone till that two structures. It's very easy that we can detect very gently, and till that here there are two structures that are very visible. That this one, what is this structure?
Middle meningeal artery.
Middle meningeal artery. I told you that you can feel till that the exposure of the middle meningeal artery and the genital petrosal nerve. When they have arisen, when they have we have reached these two structure and visible, now up to us how that there are two possibilities. Either you have to cut the tent. This is the petrous part of the temporal bone. Look at here. Now map the trajectory of this one. This is the petrous part of the temporal bone. Okay. And what is this structure? Is this one? What is this area?
Arcuate eminence.
Arcuate eminence. Excellent. But what is this triangle? Now we have discussed.
The quasi triangle.
Kawase triangle. Excellent. Okay. So now there are two approaches. First, either we have to, after explore this, if either we have to cut down the tent. We will little bit go posteriorly and we will have to cut down the tent. First ligate it because the superior petrosal sinus is there, and then this is the some portion of the superior petrosal sinus. This is so because the superior petrosal sinus is there, first ligate it and then cut down. Then what happened? Then we will give simultaneously two corridors. We will have approach the posterior fossa simultaneously and middle canal fossa now. Now there are two approaches. First, by cutting the tent, either we should go extradurally and then drill this area. Okay, we'll go and drill this area. First, this is one extradurally, and then we'll go up anterior side and we will drill that petrous apex. But below the level of this trigeminal nerve, we will go downward until that petrous apex. We will drill the petrous apex extradurally. There is a first option for us. Second option there, that we have to open the dura. We should retract the temporal lobe, and now intradurally and extradurally we have to give the we should take the exposure. Then we have to do this petrosectomy. There are two approaches, but the best thing is that this all should be extradurally. The petrosectomy should be extradurally. The best thing is that why? What are the advantages? Because there will be the less retraction of the temporal lobe. If we'll go intradural, temporal lobe will be retracted more, and we can damage the temporal lobe. And second, we can damage some venous structures like the vein of Labbe can be damaged. So extradurally, it is a good one that we will save the temporal lobe, and we have a lot of venous, and venous damage will be less. But
Dr.
there is
Gus,
yes.
we are losing your voice in between. You need to be closer to the mic.
Now
Otherwise,
it's
it's
okay.
fine. It's not the internet issue, it's the mic issue.
Now it's okay.
Yeah, it's okay. So you would just need to repeat after the vein of Labbe.
Okay, I was saying that the first option is that we have to go extradurally. We should do the extradural petrosectomy. Petrosectomy extradurally. It is very easy. We can do it after detaching the dura from it. Or we have to second option that we should, if there is a less exposure there, then what happens? We will ligate the superior petrosal sinus, then we will give the cut to the tent, then it will give more exposure to us. Now extradurally again we can do the petrosectomy. This is the first option. Second option is that we will not, while simultaneously we are also taking the exposure intradurally. We'll give the nick to the dura, we'll expose the middle canal fossa, we'll expose the posterior canal fossa, like in the previous one. This one. Okay, this is the exposure that we have cut down the tent, and we have cut down the dura in the posterior fossa, and as well as in the middle cranial fossa. Now we are getting the exposure of this one after seeing the superior petrosal sinus has been ligated, and we can see this trigeminal nerve. About to this one is the fourth nerve. Then we will go deep downward. After that, we will go to the petrosectomy. This is second option. But the best option is that the petrosectomy should be done extradurally. Then we will approach intradurally for any kind of a tumor. So, got it?
Yes, sir.
Yes, sir. You are saying in a very in a sense that you are not getting properly.
In a very feeble manner, just like the pulse of a shocked patient, Dr. Sana.
Yeah, okay, this is
रोजा
exposure.
ज्यादा लग रहा है.
Okay, this is the exposure. What I was saying that we have to go extradurally. Look at here. We have ligated this superior petrosal sinus. This is superior petrosal sinus. This is superior petrosal sinus. After ligating it here, we have cut down the superior petrosal sinus. We have exposed, we have drilled this one, that is the arcuate eminence. This is the area of arcuate eminence, where downward when we drill this one, there is a cochlea. You can see properly, the cochlea is there, and two nerves are here. Look at here, these two nerves are here. There is a facial nerve. The facial nerve will go downward here. It gives the branch superior petrosal and just the vestibulocochlear superior devian. Little bit here, look at here, there is the inferior devian of the vestibulocochlear. Now we have done the petrosectomy here. After ligating and cutting down the, you can say, the superior petrosal sinus and coagulating it, we have cut down this some portion of this petrosectomy, but it is small. It should be large till that here. Till that the trigeminal nerve from here to here, there is no any important structure. There is no any important structure. You can go very safely. Is there any important structure? Any neurovascular structure? The answer is no, because we are dealing simultaneously the superior border, anterior surface, and the posterior surface. In the posterior surface, we have only two structures, internal acoustic meatus, that is here, that have two nerves are there. We have saved this one, and anteriorly we have this portion area, that is the cochlea, we have saved, and this portion is devoid of any neurovascular structures. So we can cut down this bone, actually this one as a whole. When we will cut down here, now it's easy for us because this is the area that where is the trigeminal ganglion is there. Okay, this is the area of trigeminal ganglion, that is called, that we call it trigeminal impression is there. Just behind, medial to this trigeminal impression, we have the petrous approach. So we can go till that here easily. But below this trigeminal nerve, one thing that is important, when we are going downward below to this one important structure will be, we can face there, that is the inferior petrosal sinus. That goes posterior borderly. So this will be the trajectory through the cavase that we are going in this direction. Any question?
No, sir.
No. Okay. One option is this, and second is that we are giving the cut from the hair. This is the anterior petrosectomy. Anterior petrosectomy will give the corridor and access to all the brain stem areas. How? When we are going just above to this one, this is the fifth nerve. I will go a little bit behind to see. Okay. Look at here, this one. This is the trigeminal nerve. This is fourth nerve. Sorry, this is trigeminal nerve. This is sixth, and this is third nerve. Oh, sorry, fourth nerve is this. Okay. So this is the fourth nerve, sixth, and this will be the trigeminal one. Okay. So when look at here, when you are targeting this area above this one, so we can approach till that the R area of the brain stem, the midbrain above is the basilar artery. You can see here, and just below we can pons. But what is our target? We should go to the medulla oblongata. Then how we will approach? Our target will be, yes, please. Our target will be, now we have entered through the cavase. We will enter this one, this area below to trigeminal nerve. We will go above or downward. This is cerebellum. Look at here. This is cerebellum. So what will be our target? Where we should retract our cerebellum? Yes, please. Are you people getting? No? Are you all with me?
Yes, sir.
We are.
Are you getting or no?
I think they lost you after you started describing the medulla.
Look at here. This is the superior petrosal sinus. And what about this one, this below one? This one is going behind. Remember the anatomy. This is behind what? Which sinus? This one.
Inferior petrosal sinus, sir.
How inferior petrosal sinus will be laterally? We are on the lateral side.
Transverse sinus.
Transverse sinus. Okay. How transverse sinus? This is going downward.
So
Can I
sigmoid
ask
sinus.
something? Can I ask something, Dr. Itzaz?
Yes.
Dr. Mustafa, have you oriented yourself with the surgical field? What side are you standing on? Where's the surgeon? Dr. Mustafa?
Yes, ma'am. Yes, ma'am.
Okay, so where do you think is the surgeon's side?
On the top of the head.
No.
How top of the head?
Reorient yourself and take a look at the picture. Where is the trigeminal going?
Trigeminal is going to the left side.
Trigeminal is pointing downwards, right?
Downwards, yes, sir.
Yes, so trigeminal usually points to the surgeon. So your surgeon's
Yes.
side is downwards. You're looking this image from downwards up, and that is why you cannot differentiate between the lateral and the medial. Now, if you see yourself on the lateral side, where do you think what this structure would be that Dr. Itzaz was asking? What is lateral most major sinus?
Sigmoid sinus.
That's right.
So which sinus?
Sigmoid. Dr.
Sigmoid
Itzaz
sinus.
answered.
Okay. So this is sigmoid sinus. So just be oriented and orient yourself that where you are working. Okay. So our target will be not here. If we'll go upward, we are going upward toward the, you can say, the pons and then the midbrain. So that's why this anterior petrosectomy is an excellent approach that simultaneously you can get access to the midbrain above. We have seen the fourth nerve, we have seen the sixth nerve, we have seen the fifth nerve, and this is the pons area because 7th, 8th will be pons. But about our target will be downward. So what happens? There are two options again. First options, just cut the tent bilaterally from here and this here, and you can mobilize this superior petrosal sinus. Are you getting? We have cut
Yes,
the
sir.
tent from this here, this area, and from this area. Now you can mobilize this superior petrosal sinus. When you will mobilize, where you will mobilize this superior petrosal sinus? Yes,
Sir, towards the sigmoid sinus.
toward the sigmoid sinus, towards surgeon side or opposite side?
Towards opposite side.
Toward opposite side. Why?
To create the space.
To create the space. First thing, you can you can retract this one towards the surgeon side, but it can hurt this superior petrosal sinus. So there are two options: either retract it laterally, as will retract it laterally. Now we are at the level of, you can say, the medulla oblongata. That's the upper portion of the medulla oblongata. Because if this is a 7th, 8th nerve, now here will be the 9th, 10th, 11th, 12th nerve. You can approach the medulla oblongata. Look at here. We are seeing this one. Again, this is the look at here. It is very in a good way. Okay, this is which sinus? This is which sinus?
Superior sinus.
Sorry, this is which sinus?
Sigmoid sinus?
This is sigmoid sinus again. So now this is a picture that first we were at the level of this area in the previous one, that we have seen the 7th, 8th nerve and the upper portion of the bones. Now this is area at the level of the medulla oblongata. Are you getting this one? Because we can see these nerves that are the lower cranial nerves. Then we will retract this one, that is about you can say the superior petrosal sinus. When we retract this one and we have done the petrosectomy, by retraction we can get exposure to the lower medulla oblongata. Look at here. This whole tent has been retracted. This is second approach, that we are ligating initially at the level of origin from the superior petrosal sinus, then cut down the tent, and then we can retract the tent as a completely opposite side. Then this whole portion will be visible to us. Okay? Getting? Are you getting?
Yes.
Are you getting my point? Are people are with me? Any question?
We are with you. The voice is pretty clear if that was what you were asking.
Yes. Are you with me?
Yes.
Yes, sir. Yes.
Okay, good. Thank you. So these are the lower cranial nerves. And then we'll retract the cerebellum. Then we can see the medulla oblongata. Any lesion is there, we can access simultaneously. This is the another picture. Then we can see that, look at here, when we are going above to this one, this is the 5th nerve, we can approach superiorly, but we are going downward, we can see the lower cranial nerves very in a good way. But our target would be here in the anterior petrosectomy. So just one thing that I will add, and then we'll finish it. Okay, because I'm adding this one point, why we totally talked about this area. This is the area that we drilled this one. Just this is the trigeminal impression. With the help of this one, we drill this one, and below to trigeminal, we drill the petrous apex, then we can target this one. But what happens You have to orient yourself. If the sigmoid sinus is coming downward, when the clivus will be here, clivus is projected from above to downward, but in a slope manner, not vertically. Not vertically, it's a slope manner is this. The lower portion of the clivus, we know that it forms the anterior border of the medulla oblongata. Our target is not the top portion of the clivus. Remember one thing, our target is not the top of the clivus. When you are petrosectomy doing this one, petrous apex or this one, it doesn't mean we will approach directly horizontally to the medulla oblongata. No, because we go downward, little bit downward. Because when we are doing the petrosectomy here at the superior portion, this is the top of the clivus. When it is just coming down from the dorsum sella, so this is the area of bones. So where will be our target? Our target will be downward, go downward posteriorly towards the sigmoid sinus. This is the sigmoid sinus. Look at here, and this will be the jugular bulb. What happens when you are going downward, not go this in this direction, we have to come this direction. We come to this direction. This one, first point. And second point, this is the anterior petrosectomy. Second point is that we can do the posterior petrosectomy. When you are having the problem in the lesions for good exposure, this is the posterior petrosectomy. It's just the nibbling of the bone. Approach is same. When you will go posterior petrosectomy, what happens? You will directly go downward. When you will go do the anterior petrosectomy, we can get access all through the brain stem. So the approach is limited in the posterior petrosectomy. This is the area where we can do the posterior petrosectomy. Then we can go downward. Okay, and this will be the area when you are going through this in direction. The direction will be like this. Suppose that we have done anterior petrosectomy, we will not go above towards the trigeminal in this direction. This is wrong. We'll go like this in this direction, downward, because if we'll go topward, there is above portion that is not the area of the medulla oblongata. We'll go a little bit downward, then we will see the lower cranial, because this is the area. Look at here, and this is the landmark where you can say that you will go downward, not above. What is the landmark area? It is quite easy that you can choose this one. Look at here, this is the portion, and this is the very area. If we are going after petrosectomy above to this area, it means we are going wrong. Why wrong? Because this is the area where is the area of 7th, 8th nerve. This is the area of 7th and 8th nerve. This is the internal acoustic meatus. We have drilled this portion whole, and this is the area of cochlea. Look at, and this is the area of trigeminal, greater petrosal nerve. If we are going above to this one, that it means we are going wrong. So we have to come downward and going to this one in this direction, that so that we can approach the lower portion of the cerebellum as well as the portion of the medulla oblongata. Clear?
Yes, sir.
Dr. Motasam, we have covered parts of the petrosal anatomy in a few previous sessions, so I will be forwarding the links on the group today. The part that you are asking about is in a previous session, and that is why we are not covering the anatomy today. We are just briefly reviewing the anatomy and then covering the surgical steps.
Till that here, any question?
Yes, sir. I have two questions.
Yes.
Sir, please clear one thing. If we have to do only interior petrosectomy, then where will be the placement of our burr holes? And if there is any change or same? Or the second question is, please, exactly what are the landmarks of cutting the tent from where to where? I am unable to understand. Thank you.
Okay. If you are doing only if you want only the petrosectomy, that is the anterior petrosectomy. Okay. So this is trigeminal impression. Here is the ganglion. From here, trigeminal comes, this is the ganglion and gives 3 branches. Okay. Here and here, and that will be above, go downward, 3 branches. Okay. Are you getting?
Yes, sir.
About this one. Our target is this area. From this one to this area. This is anterior petrosectomy target. And our target will be when you are doing this one, and suppose that you are approaching this area, here is the lesion, then you have to do the petrous apex, drilling of the petrous apex. Anterior petrosectomy, including this area, petrous apex will be also drilled. If you are doing only this area, anterior petrosectomy, then what happens, and you are going extradurally, here will be the here is 2 structures that we know very well. Then one is the superior petrosal sinus, and second thing, the tent is also here. Okay, tent is coming from here, and tent is adherent like this. In this manner. Okay, this whole area is tent. Okay, tent is here, till that here, this is the tent, and till that, this one, this whole is tent. Okay, so what happens now? If you are approaching this area only, you can ligate just before this one tent, superior petrosal sinus, and coagulate it. Okay.
Okay, sir.
After that, extradurally you can delete and approach. This is one option. But if you are doing simultaneously with the posterior petrosectomy and you are trying to get more exposure, because what happens sometimes if the tent is here attached and superior petrosal sinus also there, you are going through this area only, you cannot detect this portion because there is a tent, there is superior petrosal sinus. So what happens, you will give the cut from here and you will give from here. Okay, this is one you can say the thought of the school. Then what happened, you have to ligate the tent from here. When you ligate the tent from here, it means this area is now not dangerous for you, and the tent is spared and free. We can detect this tent. When we detect this tent, we can go get the more exposure. Okay.
Okay, sir.
Now it's clear.
Yes, sir.
Yes, please. Anyone else? Anything? Any question?
Sir, is the operculum of the temporal bone is visible here?
Sorry?
Is the operculum of temporal bone is visible here, sir?
What does mean operculum of temporal bone?
Sir, it is written in the green book that this is the posterior extent of drilling of the ISA, sir. During CP angle
don't
2,
know.
sir.
Sorry?
Temporal operculum is the part of the lobe, Dr. Mustafa. We are talking about the bone here. Operculi are the part of the lobes, frontal operculum and the temporal operculum. So you will see when we are dissecting the brain. Right now we are on the bony anatomy, so we would not expect to see the opercula here.
Thank you, ma'am.
Opercula is another thing. We are talking about brain.
Yeah, I think he meant temporal operculum, just like frontal operculum.
That is far away. When you will
Yeah,
see the
that's very
salivin,
far. Yeah.
and then we will discuss those operculas.
It's around the superior temporal gyrus. So when we cover the sylvian fissure and the trans-sylvian approaches, you would get it to see it.
So any question? It's all about the anatomy. If you are very well aware of the neurovascular anatomy in a good way, you have the good command on it, then we can understand these approaches and we can get access in a good way. But if we are in a shaky, you are shaky that we are not well aware of the good neurovascular structures in the base, that it will be very dangerous for us to proceed and to get the exposure. Clear now, Dr. Mustafa?
Yes, sir. Yes, sir. Thank you very much. Thank you.
Thank you. There is no any question?
No, sir. No, sir.
So
Thank
now
you,
you can do the petrosectomy, petrosal approach. Yes, Dr. Mustafa?
You're not audible, Dr. Itzaz.
I'm audible now?
Yes, you are.
Yeah.
So now can you do the transpetrosectomy, petrosal approach?
Inshallah, sir.
Yes, sir. But
Inshallah,
under your
inshallah.
supervision.
Please just invite us. We will be there.
Inshallah. Thank you. Thank you very much. Thanks.
Okay, thank you all. If any question is there, these are a little bit tricky and difficult. We know very well, and it may be from our side. It is very not good communication. So if any question, we are always here, and we are in the learning stage as well. So we will learn from you. You will learn from us. So inshallah, we will get. So thank you all.
Thank you so
Thank you
much,
very much.
everyone. This is a wrap for
Thank you,
today's
sir.
session. We have concluded the petrosal anatomy. I will try if I can get the transcript of this video and then make a PDF handout like I did for the brainstem structures so that you can go and revise it if you still have some problems. We are going to conclude the brainstem series with the safe surgical zones of pons and midbrain tomorrow. And then we are moving on to the next session, inshallah. So that's it for today. Thank you so much. Thank you, Dr. Itzaz, for
Thank you,
taking out
Dr.
so
Kamal,
much
and
time.
thanks all.
Okay, this is a wrap.